So, folks, Dr. Leslie W. Miller is the new chairman of the Cardiovascular Sciences Department and the Edward C. Wright Professor of Medicine at the University of South Florida. Dr. Miller's clinical interests include treatment of heart failure and management of ventricular assist devices. His research focuses on stem cell therapy, new heart failure medications, heart transplant, and the role of cardiac assist devices. In fact, his topic today will be devices used for heart failure. So please help us welcome Dr. Leslie Miller.
Thank you. Well, good afternoon. I think that this is really going to become a fairly cogent topic, and forgive me for setting the stage, but I think that recalling why this is such an important topic, I think people are quite aware of the prevalence, but I think when you look at this highlighted point, it probably makes the point as much as anything. More days spent in the hospital for care of heart failure than any other diagnosis, the most expensive DRG in the Medicare health system. And a solution has to be found to reduce the readmission and the cost of this. Currently, we spend 2/3 of the cost of all of the care for heart failure patients on hospital-based care, and yet we see this as the most common readmission. So once a patient begins to be hospitalized, we really have very little that changes the natural history. This is a sobering piece of data that highlights what Medicare showed. This is from a Canadian study of about 40,000 patients that showed that in the first 30 days, 20% of people are readmitted with heart failure. And it's interesting that in a subset analysis, about 80% come back in the first 2 weeks. So that becomes a target. But it says that within 6 months, 50% of people will be back in the hospital for heart failure. And obviously there's a role in this with compliance, but look at the mortality. When a patient, this is their index hospitalization, on average, 1/3 of those patients will not survive even 1 year. So by virtue of completeness, I'm going to take us through, because the mechanical device story is not the only look at the therapies beyond oral drug therapy. And this is aquapheresis or ultrafiltration. And this is for the diuretic unresponsive patient. It certainly is gaining a lot more application as we see more and more people with advanced cardiorenal syndrome and other complexities with underlying diabetes or hypertension that makes them very difficult to achieve an adequate volume reduction or takes a great many days. This therapy is really quite well tolerated, and importantly, it's an ultrafiltrated plasma. So you don't filter creatinine or lower that, but you do filter a fairly isotonic solution such that you don't deplete potassium or other electrolytes. The important part of this data is in pilot data, this is one therapy that's been shown to reduce the readmission rate in complex heart failure in comparison to diuretic alone managed patients. And I think that's going to be an important endpoint in the future, is looking at what we do to prevent readmission and extend that time out of the hospital. This therapy, if those of you who work with it realize that it does cause a bit of a hemoconcentration and a volume contraction. The speed with which you can pull fluid is directly related to the plasma refill rate, or how much peripheral edema and interstitial pressure is present. Work we did a number of years ago in Minnesota showed that the old capillary tubes, and looking at hematocrit, was actually a very sensitive marker of intravascular volume, and that a 2 or 3 point change in hematocrit reflected hemoconcentration. That technology was so fail-safe that it's now been incorporated into the devices, and while it's not on autopilot or without supervision, it will automatically reduce the rate of filtration if they see the crit rise more than 3 or 4 points. So I think this technology is going to be something we'll look at more and more, again, for the patient who is very difficult to achieve a diuresis. I only put one slide in that I think we're going to see an expansion. Certainly we're seeing it already with home monitoring or peripheral monitoring of patients, trying to look at filling pressures in particular, trying to head off readmissions or hospitalizations. I think we're looking at a variety from lung impedance to direct measurements of right atrial pressure, surrogates of left atrial pressure. But this technology, I think, will be a part of the device management of patients with advanced heart failure. Well, the last of this kind of genre of device therapies for heart failure is cardiac resynchronization therapy. This is the trial, the Visnarenone data that just happened to look back at the incredible stratification of survival just by QRS restoration. This then became the target for this concept of resynchronizing the ventricles, particularly when there's significant dysfunction. This lead system, I think, is fairly common and known to most of you. A lead in the right atrium, a lead in the RV apex, like typical AV sequential, but then through retrograde approach through the coronary sinus, able to put a lead out on the lateral wall and capture the left ventricle without having an intra-arterial lead. And this fairly simplistic X-ray gives you a pretty good sense of how this therapy goes. I think what's important about CRT when you think about device therapy for heart failure is that it really hasn't been applied until recently in anything other than class 2 to 3 fairly standard stable heart failure. Obviously, the MADE-IT trials in Europe recently suggested there's a benefit in class 1 or 2, but importantly, this has not been applied in class 4 very advanced heart failure patients. We've kind of made that extrapolation. I think there's several trials more recently that have really called to question that when we look back on the data, the cut point where there's a reliable or predictable benefit in ventricular function and ejection fraction and patient improvement is over 150 milliseconds QRS width. So that has, I think, become more and more of a standard. When the Freedom trial was looked at in terms of using AV optimization, trying to tweak the benefit of CRT, it actually showed that at 1 year, 22% of the patients with CRT had worsening measured ejection fraction, and they turned the device back off. So I think that threshold is now becoming pretty accepted, that we certainly go through the paradigm as I think everybody would outline it, but when you're considering symptomatic patients, where you're considering BiV pacing, I think you either go past the consideration of a QRS if it's only 120 milliseconds, for example, or those who fail to look at a much more definitive mechanical support. The field of mechanical circulatory support, and I think that's really the basic terminology of what we're trying to do, and the vehicle have been ventricular assist devices. Originally, the first application was post-cardiotomy, but we've certainly now expanded into bridge to transplant and those who are not transplant candidates. But the most common category when we put this device in outside of shock is bridge to decision. We don't know if you're going to be a transplant candidate or vice versa, and we have an increasing armamentarium to treat acute cardiogenic shock. This is one of the 3 devices now that could be placed percutaneously, the so-called tandem heart. A cannula is put up the retrograde through the inferior vena cava across the intraatrial septum to directly draw left atrial blood and put it back in through the femoral vein, not trying to oxygenate the blood, just trying to amplify the amount of flow. Usually can generate 4 to 4.5 liters of flow and has been fairly successfully used. The problem is it's only been used in several centers like the Texas Heart Institute and been used in actual resuscitation. But I think its benefit is going to be enhanced. They're now developing a right ventricular support, which is an Achilles heel. But I think this has been an expanding utilization. The second percutaneous approach is the Impella device, 2 sizes, a 2.5 or 5 liter estimated flow generation. I think as you might see, the draw is from a very small centrifugal pump sitting in the left ventricular chamber and then a return just above the aortic valve. This has been fairly effectively used either by cut down or percutaneous insertion from the femoral artery, but the 2.5 seemingly is very inadequate to get people out of shock, but the 5.0 is being used more and more. The third approach is the membrane oxygenator, ECMO. This was a device used very early on in the 80s for support, but has come through a lot of evolution and is now much more effective. It was used in part for respiratory distress syndrome, where you could not only control the circulation but oxygenate the blood extracorporeally. But I think this technology has been used quite effective in people with cardiac resuscitation or really acute fulminant cardiogenic shock because it's relatively easy to apply. The last is a surgical approach, and this is a pump that has a centrifugal pump, but is done through open cardiotomy. It can support the right ventricle, the left ventricle, or both simultaneously, and has really had quite a play with patients having a left ventricular assist device and still ongoing right ventricular failure, because this pump can go for 5 to 10 to now over 30 days of support. Allows you to wean, turn down the speed and the flow and support of the pump, and see if native ventricular, right ventricular function is improving. Quite an effective tool for cardiogenic shock. Well, the concept of mechanical support is obviously a very rapidly evolving and growing phenomenon. I think you can see here in comparison to the purple bars, which are transplant, which clearly show you that over the last decade, the numbers have really not increased at all. We're really pretty much limited at 2,200 transplants per year. But in contrast, you can see both internationally and particularly in North America, there's a rather dramatic increase in the application of chronic mechanical support of the heart and circulation through ventricular assist devices. This field is growing dramatically. The technology has changed from an extracorporeal pump that you could wear outside the body to now totally implantable, and very soon a driveline-free type of mechanical support that have been miniaturized, as I'll show you, down to the size of a pin-light battery. The first application that we see the greatest use of this technology is the indication as a bridge to transplant. Patients who either present to us who are transplant candidates but are in such severe end-stage heart failure that they will clearly not survive to a transplant, and that's called bridge to transplant. And you can see nationally that about 30% of the patients who go to transplant in the United States today do so on a mechanical device. In areas where there's a limited donor availability, it can be as high as 75% of these patients. That's in part because of the increasing size, preformed antibodies, pulmonary hypertension, obesity, a number of things that make it difficult to go and find an ideal donor. And so more and more patients, and in the face of the ever-increasing outcomes, are going to transplant on a mechanical device. This slide really gives you a portrayal of the mechanism of the two basic devices. The first generation pump on the left really simulated left ventricular function. You can see on the top, that's the LV apex, a large cannula draining all the blood out of the ventricle into a preformed sac, and then ejects the blood in a pulsatile manner. It can follow AFib, VTAC, whatever the native cardiac function is, it will eject whatever volume is in that sac at that time and returns in a typical pulsatile manner. But the second generation, which really has made the greatest change in the field, are what's called continuous flow devices. Here pictures the only moving part, the single rotor that pulls blood out of the ventricle on a continuous basis. And as you might see, there is no pulsatility. It returns blood flow to the body in a mean, non-phasic pattern, which is a dramatic change from all that we understood in circulatory physiology of primates and mammals, and that is that critical organs needed pulsatile blood flow. That's clearly been shown to not be the case. These patients don't have a palpable pulse. Their blood pressure has to be taken by a Doppler probe, and yet we know their organ function is completely normal. This is a look at how much that size comparison, despite the mechanism, 1/7 the size, 1/5 the weight, dramatic change. In addition, these are silent in operation. Tremendous advance for patient acceptability with mechanical support. One of the things that's changed as a cardiologist, we're all basically physiologists. This technology now gives us the ability to change preload online. We can adjust the RPM speed and go from the bottom panel, where it's very slow and not generating much flow, where there's completely pulsatile circulation, to turning the speed up to where there's very little preload, there's no ejection, no opening of the aortic valve, and we end up with non-pulsatile flow that, again, more than adequately supports the circulation. But that ability to change preload online is an extraordinary advance in our management of these patients. This is what the technology would look like in a patient with battery-powered support of this pump worn externally. And as I said, before very long, we'll have no driveline externally at all, completely implantable systems, but quite acceptable for the patient. There's been an increasing amount of data. This was the original study in yellow that we showed in patients with a bridge to transplant who had about a 90% chance of 6-month mortality because of the severity of their heart failure and shock. And you can see at this stage in the first cohort, 77% 6-month survival. And with more experience, the same centers, the same trial, waiting for the FDA to give us approval, you can see that surgical experience had another 10% improvement. So it's an observation that we've seen in every surgical trial. Experience lends to much better outcomes, but a tremendous change from anything we'd ever had before. But what's important about the device is they don't only improve survival, they improve functional capacity. Shown on this slide are 4 recently published CRT trials and the change in 6-minute total walk distance. And I think you can see it's a mean right at 40 meters increase. In contrast with mechanical support, the increase is on average 300 meters. So this really makes a dramatic change in their functional capacity. Quality of life is greater than any drug therapy trial. And this just shows you not only did it improve from the 68 to 87, now you can see 91% 6-month survival. And these curves are flattening out, meaning that the durability of these devices is so much greater and leads to what we think is going to be a big cost reduction in preventing readmission. As I suggested, this field is going very rapidly, and we're already at a 3rd generation of pump. And this is a big advance. I think you can see the relative size. This is a small pin-light battery in size in your hand, has magnetically levitated centrifugal flow such that there's no blood interface with the textured device. And importantly, it is able to sit in the cardiac ventricle and within the mediastinum. So there's no pocket developed for this pump. It sits totally implantable and is much smaller than anything we've had before. Much like everything else, the more we do with this technology, I think you can see I showed you that we're able to generate 70, then 80, now 90%. This trial also shows 90% plus 6-month survival. But what's important is the line in red. The control group here was from a registry maintained by the NIH and CMS. And that says people not involved in trials who are gaining experience with this device can also generate 90% 6-month survival. This technology is now ready to go out into very effective cardiac surgical programs around the country with good results. This is, I think, an X-ray gives you a sense of the size comparison. Here's that large pulsatile device in the upper left, the HeartMate 2 with a pocket dissected and shown here on the upper right, and the Heartware pump in the lower left, and superimposable now you can see the rather impressive reduction in size. And much like everything else, this technology is really designed not for the transplant patient or transplant candidate, but for all those people where heart failure begins to increase over the age of 65 who may not be transplant candidates, we refer to now as destination therapy, meaning they're not going on to another procedure. And I think like the previous slides I showed you, in blue was the early part of the trial, in black the overall experience, and in red the late experience. You can get a sense of how much improvement you can see within a short period of time with new technology using these devices. And most of all, this is a rather outrageous trial that was reported from San Diego because people would say, well, where do you cut off? How can we afford this kind of technology in older and older patients? Well, this trial was led by an 88-year-old recipient. And right off the bat, you say, everybody's hysterical, this field's gone crazy. But he was hosting his 3rd golf tournament and running his 2nd company. It's the old, physiologic and chronologic age. But they looked at a series of 30 patients above and below the age of 70 and could find no difference in outcome in that population where heart failure is so prevalent. Every cardiologist, by and large, is holding on to a number of patients over 65 where we figured there really isn't anything to do, but I would submit that this therapy is really quite an alternative. And like everything I've shown you, this technology keeps getting smaller and smaller and smaller. Here was the Heartware pump, and then you can see how much the smaller one is, about half that size. Similarly, the Heartware pump is getting miniaturized. We'll be able to put these in both right and left side with real ease and simplicity and a single driver. And this technology is going to be in clinical trial within the next year and a half. The trial that's ongoing now in the United States, about to be up and rolling, is called the Circulite pump. This, imagine, is like putting in a pacemaker. This can be the province of the cardiologist because it literally is a pocket here where you're inserting a drainage cannula, much like that tandem heart that I showed you, that goes across the atrial septum and drains the left atrium and brings blood back and puts it back into the subclavian artery for return. And I think this is going to be a very impressive trial. It generates about 3 liters. The question is catching people before they get into hospitalization and care. And as I said, this is the invasive approach that would be the typical surgical approach to therapy. But I think we're going to see a percutaneous approach that will simply be the province of the cardiologist. But lastly, I think what I'm trying to show you about these devices is it's no longer the critical patient in shock with end-stage heart failure and multi-organ failure that we're really targeting for this type of therapy. Right now in most centers across the country, almost all devices are going in as an elective operation, and an increasing percentage are actually coming from home. Evaluated, decided that they needed a device, they go home for 2 or 3 days, get away from nosocomial infection, sleep in their own bed or rested, don't come in exhausted and malnourished, and their outcomes are dramatically better. When we looked at length of stay of people who were in the hospital, inotrope dependent, are doing poorly, the average hospital stay was 40 days. In those patients who came from home electively, the average stay was 12 to 14 days. That cost reduction is going to change this field, change our approach. It's not changing entirely into a less sick population. It just says, I think we can do this therapy much more effectively. So I think that you're going to see what I said in the initial slide, that when people become refractory to oral medical therapy, it becomes the province of some type of surgical procedure or device. I think I've shown you both in-hospital, out-of-hospital modalities, but the mechanical circulatory support using temporary, but more importantly, chronic ventricular assist devices, I think is going to become an ever-increasing part of the armamentarium of options for treating patients with advanced heart failure. Just as a final aside, the equipoise, meaning I don't think I know what's better, this stop therapy or that therapy, has come to a level within the heart failure community that the NIH is doing a randomized trial of medical therapy today, CRT, whatever you want to do in today's world, versus mechanical circulatory support head-to-head. I think that's as good a testimony that's saying the field believes this technology is here. The outcomes are as good, if not superior, to transplantation. We've got 250,000 people with advanced or end-stage heart failure. We've got 2,200 donors. We have got to develop some type of strategy to effectively and definitively take care of those patients. I'll stop there and happy to answer any questions. Thank you for your time.
Fantastic. Thank you so much, Dr. Miller.